Good evening, everybody, and welcome to our webinar tonight on electronic prescribing for GPs and pharmacists. My name is Sonia Zara. I'm one of the Quality Improvement Program Officers in the Quality Improvement team at the PHN. I'd like to do an acknowledgement of country now. The Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. Just before we get started with our presentations today or tonight, I would like to do some housekeeping. So all attendees are muted. Please keep your microphones on mute. Please ask questions via the question box or raise your hand. Q&A will be at the end of the presentation. Only presentation component of this session is being filmed. Any questions will be edited out to protect your privacy. We've got some great education and education training sessions coming up. So there's a list over here. You can actually register online for all our upcoming education and training. That's on our website, I should say. So we have some really good ones there. As you can see, in March, we've got the NDIS, we've got the cardiovascular disease. Also, we've got the COVID vaccination rollout in the Northwestern Melbourne PHN. The eyelid function, lumps, bumps and cancer of the eye, and marketing 101 using digital platforms to grow your practice. We're just promoting our health pathways here. Sorry, my computer just clicked over to the next screen by accident. Yeah, we just like to let you all know we're so excited at the Primary Health Network that we have 750 pathways for GPs to use at the point of care. So if you haven't used the Health Pathways Melbourne page, please contact your relationship manager at the PHN and we will get you started on the Health Pathways, which is an excellent resource for general practitioners and practice nurses. We would like to ask you if you have any specific interest in key topics such as practice management, human resources, quality improvement, or diabetes or pediatrics. You can join our think tank to be the first to hear about opportunities to get involved with our PHN. So please, if you have any interest, please give us a call or an email and we'll be happy to have you involved. So our agenda for tonight, we have 4 presenters. We've got Andrew Robinson, Rachel Hewitt, Ben Kang and April Burnett. We're going to be starting with Andrew Robinson, the pharmacist at Turunga Pharmacy, who will be providing an introduction to e-prescribing. So I'll hand you over to Andrew now. Thank you, Andrew.
Thanks, Sonia. All right. Okay. So welcome everybody. This evening's quite warm, so hopefully you're getting some nice air conditioning in your own homes. Sorry we can't be all together, but for the moment webinars is the way we're doing this. So a bit of quick background on myself. I'm a pharmacist. I've been involved with the pharmacist digital health leaders for the ADHA, and I've been helping roll out trainings and explain some of the new and emerging technologies for the Digital Health Authority, and we're now gone through the My Health Record and we're into the digital prescription space. So we'll get started straight away. So electronic prescriptions are now becoming more and more commonplace. Some of you may have already seen them and you're here tonight to get a bit more insight into where we're at with it. And some of you may not have had the experience with them as yet. So feel free to ask questions. We will try and get to them towards the end once the presentation is done. All right, so what are electronic prescriptions? Well, electronic prescriptions essentially just are an alternative to paper prescriptions. There's nothing particularly tricky about them, but they do offer a whole lot of benefits. Previously, we could only use a paper prescription. That was the only legal prescription. It had to be signed by the prescriber, and it gave the instructions on which medicines to be supplied. A lot of people get confused about the legalities of the electronic prescription and how certain ones may or may not meet the requirements. There's legislation in both state and federally to allow for electronic prescriptions. So some of the legislation around electronic prescriptions doesn't say or stipulate specifically some of the details that has previously been required for normal paper prescriptions. And the reason why it doesn't reference anything to those particular areas of legislation is because they're not required for electronic prescriptions. For example, the hand endorsing of Schedule 8 medication. Obviously, you can't do that in an electronic prescription, but one of the reasons why that requirement for handwritten prescriptions was there is to reduce the chance of forgery. And as electronic prescriptions are highly secure as far as their authentication, they don't have the same requirement for that to try and prevent forgery. They won't be mandatory. I think some people were worried that e-prescriptions would take over and replace paper prescriptions. They're not. They're an addition to the options for patients and for prescribers. So it comes down to a choice. Some prescribers may be very comfortable with it, but the patient may not be. Some doctors may not like the idea of having the e-script, but the patients are really e-health enabled and really want to use that functionality, and we'll show you some of the benefits of that as we go through. So it's going to be a choice for both prescribers and for patients. All right. Okay, so why are they important? Well, it provides greater choice for patients, but it has the added benefit of better integrity, security, and giving information from the doctor to the pharmacy without transcription errors, so data integrity is improved. It provides a chance for doctors to still be able to provide prescriptions to their patients without seeing them face to face, which is particularly relevant now, and one of the reasons why this is so timely, with COVID being such a dominant feature of our healthcare at the moment. Having an ability to provide care for patients via telehealth or other means, this gives a way of getting a legal prescription to them without having to physically see them and have them come face to face and pick up a prescription. It's a lot less messing around with paper prescriptions. All pharmacists know how it can be such a juggle to manage lots and lots of paper, bits of repeat form and original prescription backings. People have scrunched it up in their handbag, left it in their car for months and months on end, and so they become a real mess. Sometimes they're defaced, even sometimes to the point the directions and prescription information is smudged off. So they've got the integrity that paper prescriptions will never have. It can be more efficient for pharmacies. I know some pharmacies are concerned about the workflow on e-prescriptions in relation to their current workflow, and that is a genuine concern, but in my experience, it's not one that is not that hard to overcome, and we'll talk a little bit about that as well. And if you have particular questions, you can ask them at the end. It can reduce the prescribing and dispensing errors, transcription errors, simple mistakes using scanners and pre-populated information certainly helps reduce that. I will hasten to add, though, it does not take away from clinical judgment. It does not take away from being alert to poor data from the prescriber, and the information may come through incorrectly. If it's, as in any other patient group with a prescription, there may be an error on it, so it doesn't replace being careful. And sometimes e-script matching, for whatever reason, doesn't quite align, and some examples of that would be where I've had patients where their first name, their Medicare name is you know, Robert, but they might have Bob in your system, and that can sometimes cause an issue if there is another Bob in the system. So that can be a little issue. So it doesn't take away from being careful. You still need to do your usual due diligence. You're checking it's the right patient, it's the right medication, but it certainly can reduce the chance of that. And it continues to support the more broad shift in healthcare to a more digitalised healthcare system and telehealth services with COVID in particular. All right, so what can they be used for? Well, essentially everything. Everything a paper prescription is and does, the electronic prescription does, all PBS medications, authority prescriptions, Regulation 49, which is the old Reg 24, private prescriptions, so non-PBS, and Schedule A. So they basically fully complement the system we have. So e-prescriptions can come in a variety of ways, and you've probably heard a lot of talk about tokens and active script list, but for those of you who haven't, so far with the rollout, we've seen the introduction of token prescriptions. So that's essentially using an electronic token that acts in lieu of a paper prescription. So it's one for one token for one item, like one prescription for one item, one paper prescription for one item. The patient would get multiple tokens if they have multiple items. And generally it's sent to them directly into their email or via SMS to their phone, and then they can use that at the pharmacy, and that acts as a key, like a digital key. So it's not the prescription itself. The prescription sits in the prescription exchange service, and that sits there until someone comes along with the key to verify that that prescription is for that patient, and you have to have conformance software to be able to access that. The active script list is a slight variation on that. So an active script list allows all tokens to aggregate together. So it will have the ability to have a complete list of people's tokens. And one thing that tokens have a problem with is that people can still delete them, just like they can lose a paper script. We've got some little ways of working around that, and storage solutions and ways to help people manage that. But you know, that is still a possibility. With the active script list, it'll sit in that database and be available for the pharmacist to pull that down. So the doctor would prescribe that e-script, electronic script, and it would then sit into a patient's active script list. This will be really suitable for patients where they've got a lot of medications, so they'll be getting a lot of tokens. It becomes difficult for them to manage, and it will also be really useful for patients that are not as electronically or digitally enabled and not so keen on managing it themselves, but also appreciate the ability of digital scripts to afford them flexibility and security that paper prescriptions can't. And I'd use an example where if someone goes on holiday, they've been a regular customer of yours in the pharmacy, they leave their prescriptions on file, they go away, they leave their pills at home, they leave the prescription is at the pharmacy, and they need to get a prescription, and that is not easily done. Either the patient contacts the doctor and the doctor sends a new script to a different pharmacy wherever they are on holidays, or the pharmacy, if they've still got repeats on file, the patient may contact the pharmacy, and you have to then organise for that physical paper prescription to be sent via post to the supplying pharmacy. So an active script list or token would overcome a lot of those issues. The good thing is dispensers can also access that prescription, so they can know what patients have actively sitting in their script list, and it aggregates those for the prescriber, the pharmacist, and potentially patient if they want to access it to see. That is imminent. It's not available just yet, but it is coming very, very soon. And you can see here from the diagram how this would sort of work. So you've got your patient, and they can choose which way they manage this. You've got your doctor and your pharmacist, they're dispensing, and allowing both of those parties to assist the patient with their electronic prescriptions. So how might people use their electronic prescriptions? Well, this is maybe a little ahead of where we're at the moment, but they need an active script list. So an ASL at the moment is going to initially be pharmacist supported registration. So essentially a patient would come in to their pharmacy, the pharmacist would assist them in registering them for an active script list. It'll be an opt-in. It'll be similar to, but different from the My Health record when it first came out, where that was an opt-in and you could do an assisted registration. It'll be easier than that. It'll essentially just be getting consent for those patients to have their electronic record set up and have somewhere to aggregate those electronic tokens. So the patient would come in and ask about it, or the pharmacist may mention it to a patient, gee, you've got a lot of tokens, you've got a lot of medications, this might be an easier way for us to help you manage that bundle of tokens that you've got, because it can be overwhelming, just like paper prescriptions can be overwhelming for some of our patients that have a lot of them. It can get confusing, and now we've got ingredient prescribing, active ingredient prescribing. It's going to be even more confusing for some patients if they're not familiar with their medication names. So when they've got a whole lot of tokens with a whole lot of funny names to them, they're really not going to have much of an idea of what they're taking from their token list. So the pharmacist would help with that registration, and then the pharmacy gets consent to use and access that active script list. If a patient already has an active script list, when they see their GP, they can request that electronic script is automatically added to their active script list. They can also get the token direct to their phone via SMS or email. And when they go to the pharmacy, they can either do one of two things: let the pharmacy know there's a script there in their active script list, and the pharmacy just pulls that down and accesses it through the active script list database, or they may still use their token, which they can then do the same thing and open that electronic prescription. Many people really like tokens in that it is very good for things where there might be a one-off, like an antibiotic course. A lot of patients don't use a lot of prescriptions, don't necessarily see their doctor very often, and it will be a very convenient way for those patients to get a prescription. It's also something to keep in mind from the prescriber's point of view, that if they have a patient and they give them electronic token prescription, they can always cancel that. Once you've written a paper prescription, that paper prescription's out there, and if you've got 5 repeats on it and subsequently later find out that that patient may have been misusing medication or has had a problem with that medication, had a reaction to that medication, you can actually then inactivate that token. So that allows for better safety, patient safety, medication safety, and that's definitely one of the pillars of the health strategy at the moment around medication safety. And a lot of patients are now using apps. There's a couple of really good ones out there that have the ability to help patients store their tokens like a digital wallet. So those tokens will come in and then they can be stored in that app. That app will allow patients to see the scripts the doctors prescribe them. They can add them in there. The repeats will stay there. They can order them from the pharmacy. They're very powerful for helping patients manage these prescriptions. These apps have been around prior to digital prescriptions. They're being used for paper prescriptions, especially where patients may leave those paper prescriptions on the pharmacy's file. But now with digital prescriptions, that's going to make it even more relevant and more useful for patients. So really, really important for these patients to be able to see and understand their medication. They often have things like patient information attached to those apps. It tells them how many repeats they've got, which makes it a bit easier, because sometimes having the script number and the number of repeats can be a bit confusing. When it sort of aggregates multiple scripts, it just gives them a total, and it makes it a lot easier for those patients to manage and know what they've got. The good thing with that is that also patients will know if they've got a script when they don't think they've run out, they don't think they've got one. They're often then contacting their doctor to get a new prescription, which they may not actually need. It's happened several times, even just recently, where I've had patients have gone to their GP specifically for a script that they already had. Partly that could have been ingredient prescribing, causing a bit of confusion, but certainly where you've got an app that aggregates that, that'll definitely help patients and reduce the time burden for the patient and the GP on prescribing or writing new prescriptions that aren't necessary. So importantly, people often associate digital with potential scams and dodgy things, but the reality is there are plenty of scammers and dodgy people out there trying to fob off paper prescriptions to pharmacists all the time, and I see this as a huge step up in security and safety. Software has to be conformant at the doctor's end, prescribing, at the pharmacy's end when dispensing, and for any of these apps that use storage mechanisms for the tokens and help people with medication management, all conformant with the requirements of the Digital Health Authority. Not only do you need conformant software, you also need to be registered to connect to the digital services. So the Health Identifier Service Registration, you connect your HPIO, which is the Health Provider Identifier for an organisation, the PKI is the NASH, the HPII for the individuals. So even the individual pharmacist or doctor prescribing and dispensing these have to be identified. So this can be audited all the way along, and there is a really strong level of security to support all this in the background. Whenever you dispense, and I presume from the prescribing side, rather than signing with a doctor on a signature on a prescription, they still have to put in a password to issue that prescription. And likewise, when we dispense it, the pharmacist puts in a password each time. There's some efficiencies that have been coming out in the software, and appreciate that some of this is really new, and the software vendors are constantly improving their software to make life a bit easier. And thanks to those early adopters who have been piloting these things and trialing them and putting them through their paces and ironing out some of those little things that are just more irritations than anything else, they're making them more and more efficient with those sort of things. The information is encrypted. It goes to the prescription data service, so it sits there and it doesn't go anywhere else. So it's a secure repository of those tokens, and you can only access those tokens if you have access those prescriptions if you have the token, like the key to the door. So you really have very high level of security around where those tokens can be used to access the database, and who, following the audit trail, who has accessed that database. The contents in people's emails and SMSs when they come from the doctors is minimal. It's usually a hyperlink to create what is described as like a QR code, and that's just for ease of use, to be able to scan that in and then access the actual digital prescription. When the SMS goes out from the doctor, it'll say AR has a script for the medication name, has no date of birth, it has no name, no identifying information on that. So it's only when it comes through the conformance software we'll get a, I suppose, a rendered image of what a prescription might look like, because obviously a digital prescription in the background from the IT boffins looks very, very different to what we're used to in the land of doctors and pharmacists seeing a physical prescription. All the information's there, but it's not presented that way. So the software brings it to present it in a way that we're familiar with it. But on the patient's phone or email, there's very minimal information. Oh, sorry. The prescription will then tell you when you hit that token whether it's already been dispensed or if it's cancelled or expired. So that's another big thing, is expired prescriptions. Patients often don't realise they've got a pill script from last year, for example, and they come in wanting it dispensed only to find out it's expired. With digital prescriptions, it'll tell them that in advance. If they click on that link, they'll know straight away that that prescription's expired, and it'll save that conversation in the pharmacy, and it can speed up the whole process and reduce wasted time. So this is the doctor's software, which I'm not as familiar with, so I have to apologise, not being a doctor, not using practice software. But basically, instead of printing a prescription, you just change the actual delivery method for the patient to the type of prescription they want and how it's delivered. So if it's going to be a token, whether it's an SMS, if you're going to send it by SMS, check the SMS number that you're delivering it to. You don't want that token going to the wrong person. It's important to make sure the patient has actually got that token before they leave the practice. That's our preferred way of making sure that things have worked. Email is another great way of doing it. I personally like the email method because people, even if they do accidentally delete it, they can generally pull it out of trash. Once they delete an SMS, it's gone. The other advantage of an email is they can put in folders, and they can make sure that if they're not using a method of either an active script list or using an app, that those tokens are put somewhere safe that they can find. Because I can tell you, having now been doing these for well over 6 months, patients do forget that they've got tokens, where they put the tokens. They may have deleted it, not realising that SMS was even a prescription. So it does happen where patients, if they're not using those immediately, do lose them and can't find them. So it's something to be aware of. Make sure that they've got it. Make sure you're setting it to the right number, because that could constitute a privacy breach if someone were to then take that token to try and get it dispensed. But the good thing is, if you realise that you've sent it to the wrong number, as soon as you do, you can cancel it, and that token will no longer work. So basically, the prescription is a discussion for the GP with the patient, and they will then decide how best to get that token to the patient. That patient will then go to the pharmacy and use it in the way they see fit, whether they download it through an email or whether they take in their SMS straight into the pharmacy on their phone. So this is what the patient will see on their phone if they get an SMS. So they'll get a message saying that you've got an electronic prescription. And when they click on that message, they go in to see the hyperlink for that medication, and it takes them to a rendering service that creates this QR code. And the QR code will then have, I suppose, act as the key from the pharmacy. Scanning that in will take it straight into their software and allow them to access that digital prescription from the exchange. If something, for whatever reason, doesn't render, this number underneath the QR code, if you can see it, the 21KR, that number is the actual barcode. And so if for whatever reason the message didn't render into this image, you can just type that in or copy and paste that code in, and it will do the same thing. But scanning the QR code is obviously more efficient, time-saving way of doing it. And you can see the different two different providers, ERX and MediSecure there, have slightly different look, but essentially the same. And that'll be determined by the exchange that the prescriber is using. They'll be using either ERX or MediSecure, as pharmacy does as well. So the scenario here, so just so I'm out of the way, you can see that. So the patient accidentally deletes a token from their device. So the good thing is, rather than having to reprint and re-sign and do the prescription posted or to the patient or the pharmacy, the prescriber can just resend the original token to the patient. And if it's been after the first dispensing, the pharmacy can do it. So that makes it a lot easier for those moments where patients have accidentally done something with their prescription, or the dog ate it, who knows, but prescriptions go missing and get destroyed all the time. As I was sort of indicating before, if the token's sent to the wrong number, the prescriber can just simply cancel it. And the person who's got that, when they try and take that token to a pharmacy, it's not going to do anything. That lock's been changed, the key doesn't work. If the patient is unable to receive a token, so they don't have a smartphone, they don't do emails, they can have an e-script, but it can be printed on paper. That's not the preferred way. We'd rather not do it that way, but it still allows for the script to go on the active script list. And so if the patient's really happy with their doctor and pharmacist and the relationship they've got with them, and trust them to do their medication management for them, that can still work as an alternative. Otherwise, the patient should then just get an original type prescription, paper prescription. So when patients are accessing their prescription repeats, the patient will have a new token, just like when we're dispensing a prescription in the pharmacy right now and we print a new yellow duplicate repeat form. We will also be doing a new token. So it replaces the other one because it's the next dispensing. So if it's 5-1, 5-2, 5-3 on the repeats, it'll be replacing it just like a paper prescription would. So it's important that patients understand they're going to receive a new token, and they'll need to either manage that in their email or their SMS and not delete the wrong one thinking it's not the actual prescription, because it'll replace the previous one and they'll get a new message. Are there safeguards to prevent patients using their tokens at multiple pharmacies? So this is another really good security feature of tokens, is once it's been used and dispensed, it no longer works. It's a once-off prescription. So all this auditing in the background makes them very secure. They cannot be used, they cannot be duplicated, they cannot be forged. They are a much more secure way of knowing that those scripts coming through are legitimately coming from a conformance software, from a doctor with an HPII, and their site has a certificate that's registered with the Digital Health Authority, and likewise the pharmacy can be receiving them, can be authenticated in the same way, and so any tokens coming from them are legitimate. Will the software cater to legislative requirements of individual states and territories? This was a huge query early on. Basically, there is a lot of work done on this space, and for the most part, I believe that all the softwares are compliant, doing what they need to do. They meet all the obligations, or the states have changed the legislations to make digital prescriptions a thing. So like that example with the Schedule 8 items, where they normally have to be written in words and figures and handwritten, or benzodiazepines, they obviously are no longer required to be handwritten, because there's a whole lot of other ways to verify it rather than just knowing the doctor's handwriting. So what certificates do you require to participate? So basically you've got a bit of stuff. I would, rather than dwell on this, I'd direct you to your PHN if you haven't already enabled eHealth, so My Health Record or any of those other digital things, and making sure you're also using e-scripts. Then you'll need to do some work in the background to get yourself ready, and the PHNs are really well equipped to help make sure you're getting all the bits you need, and the Digital Health Authority are also really helpful in making sure that you've got everything you need. But there are a few requirements to set that up to get conformant. Importantly, it's not hard. It was hard 10 years ago when I did it, but it's a lot easier now. There used to be pages and pages of documents. Now it's a very, very simple process, and most of you will already be, if not fully set up and not even realise it, you'll be close to fully set up if you're using things like ERX Exchange or the MediSecure Exchange. Do electronic prescriptions still work for prescribers if ERX or MediSecure is not installed? Fundamentally, no, because they don't have an active prescription delivery service. You need to be able to deliver those conformant prescriptions, those digital prescriptions, to somewhere. And if you're not connected, you can't create them and they can't be stored there. So you do need to be using one of those softwares. So just a bit of a checklist here if you're not already eHealth enabled. You need to make sure your organisation is registered with a HPIO, so that's the Health Provider Identifier Organisation. Then you've got your security certificates you'll need as well. So the Medicare PKI allows you to access those health identifier services and link individuals to your organisation. Pharmacy, same as the GP, you have to be connected to the prescription delivery service. I believe pretty much every pharmacy is. There may be some that are not, but if you're not, again, speak to the PHN. They're a wonderful resource for helping with digital health. And you need the software to be able to manage all this, so making sure your software is up to date. And this is becoming more and more critically important with PBS changes all the time. E-scripts are going to reject a lot more than paper scripts if they're not right. In the past, GPs might have written a streamlined code that was an old one or something like that, and the pharmacists would just, you know, make their magic happen and call the doctor, endorse the script and push it through, and it would be all okay. But now that they're all going through these rigorous auditing and validation processes, they need to be right. They need to have up-to-date data. So databases on both the doctor's side and pharmacist side need to be up to date. They can't wait 2 weeks into the month to get the last month's update. So it's really important to keep up to date. And really important to make sure your patient's details are correct. Now that we're going to have a new way of communicating with patients, being their SMS or email, that may be information we've not had in our dispense software or our prescribing software previously. You would have probably had a contact number, but not necessarily their mobile, and certainly not email. So that is something that's new, and we need to get ready to start collecting that data, because it's the only way we can get those tokens back to those patients. So it's important to stay up to date with all the relevant legislation. As I say, PSA have a really good thing for pharmacists in relation to each state by state legislation and questions, FAQs for state by state. That's been a really useful resource for many, many people. Workflow is really important, particularly in the pharmacy setting. The doctor's setting is really quite a simple scenario. The patient comes in, you discuss if they want an e-script, and you choose to send an e-script. From the pharmacist's point of view, that is multimodal for us in pharmacy, because we have prescriptions coming in with patients walking in with a physical prescription. We have them walking in with a token. We have them sending them in electronically through the new platforms that are becoming available with digital prescriptions. We also have faxes. We have emails with PHEO 4 legislation still in place until the end of March. We're still dealing with scripts coming through that way, and they are legal, legitimate prescriptions, but then some of them need to still have the physical script. So that's where the digital scripts are going to certainly come into their own once the PHEO 4 legislation expires, that emergency health order that allows for faxing or digital images of prescriptions. So a fax or a scanned copy of a script is a legal prescription in Victoria until the end of March, unless it's a Schedule 8 or a drug of dependence like a benzo. So this will certainly make it a lot easier for doctors in that side of things. But from the pharmacist side, there's a lot of ways that scripts can come in. So knowing what best works for your business, your pharmacy, is going to be important to make sure you can accommodate the influx of digital prescriptions. It's really good to work with your local GP. We were part of a pilot with a community of interest in the very, very early days of the rollout. And that was great. It was really nice to be able to work with our GP on a particular project rather than just calls backwards and forwards where there's particular issues. They were fantastic. They were really on board with it. So much so they were sending us a lot of work with some of their older customers who had no idea what was going on. But the point is that they were really engaged, and actually the oldies were really engaged too. They were really keen to show how modern they were and really enjoyed doing it. It did make a bit of extra work to get those patients enabled and work out how to use it, but really it's been worth the effort, and it's going to become more and more commonplace, and people are becoming more and more comfortable with it. The ADHA, the Digital Health Agency, has got information there on their website as well. So that's to the end of my presentation. I think that leads nicely into the actual GP and pharmacists we have on tonight, because they can talk a bit about that collaboration of working together, how they've managed to make the transition from their patients on paper prescriptions to patients with digital prescriptions. But I'll give you one anecdote from my personal experience. Our GP and us shared a customer who happened to have a holiday house down at Anglesea. Now, for pharmacists that are aware, Anglesea was the first pharmacy in Australia to do a digital prescription, dispense a digital prescription, as it was from the Anglesea GP. So that was the first community of interest. And coincidentally, my customer happened to have a holiday house down there when the first lockdown happened and the Ring of Steel in Melbourne came. And funnily enough, she was also our first customer to have a digital script. So it was obviously meant to be. But the GP had given her a digital prescription, and when the lockdown happened, she didn't have her physical prescriptions with her. She left them with us, normally, the paper ones. And so she was down in Anglesea, and she rang me and goes, "Oh, I've left my scripts up in Melbourne. I'm not going to have enough tablets to get me back until the Ring of Steel comes down." And I said, "Well, isn't it great that you happen to be right next door to the pharmacy in Australia that had the first digital script, and you can go there and take that token that we sent back to you?" And she was rapt. So the customer satisfaction, the patient satisfaction, the lack of extra time on GPs to get another script, or for us to have to post a script down to her holiday house, was phenomenal. And it really shows the power of this, the flexibility of it, but also the security around it to make sure that the right person's getting the right prescription. So I'll hand over now to the guys to talk through that relationship between general practice and their local pharmacy.
Thanks, Andrew. It's Sonia here. I just thought, just before we go ahead with the team from the Crane General Practice, There's lots and lots of questions, so thank you very much to everyone that's asked those questions. Just so you know, they are all being answered by April, so have a look on the question pane, and you can see there all the answers. So please continue asking questions as we go throughout the presentation. And now I hand you over to Rachel and Dr. Lim. Thank you, Rachel and Dr. Lim.
Thanks, Sonia. My name is Hui, and this is Rachel, our practice manager. I'm the principal GP of the Crane General Practice. First of all, I would like to acknowledge the traditional owners of the land, which is the Wurundjeri people, and also like to thank Andrew for such an informative session, which we probably had before we embraced eScript. We are a pretty young practice that started at the peak of COVID in April last year. And I guess being a smaller, young practice, embracing change was probably easier than some bigger, long-standing practices. Like many of you would know, we face many challenges in general practice, and we're constantly looking for ways to deal with these challenges. So specifically safety, such as infection control to keep our staff and patients safe. People, so trying to reduce staff inefficiencies and overtime. And of course, money, trying to keep our overheads low while running a quality practice. And all these challenges became very much more evident in COVID. And we were desperate for various measures to manage these. So during the lockdown in Melbourne, before eScript, we had lots of lost scripts, lots of faxing, lots of lost faxes, lots of time wasted, essentially, and really unhappy staff overall, and lots of overtime to pay. So when eScript came around, we got very excited, but we had to obviously contemplate and weigh out the pros and potential pitfalls of it. So we contemplated to eScript or not. Andrew has probably covered most of the pros here. So they dealt with the challenges that I covered at the start of the presentation, which were firstly safety. So it was mostly contactless. So from an infection control point of view, it was excellent. And it was secure, and it complemented telehealth really well in terms of workflow. From a people point of view, it was very efficient for the staff. There was less handling, there was less physical storage, and happier staff. And then finally, from a cost point of view, there were a couple of questions about the cost. Initially, it was free to eScript, and now it costs about 4 cents to send an SMS through best practice. And if you do it by email, it's free. And so from a cost point of view, it was cost effective from other perspectives, like less printing, less faxing, less posting, less overtime. And then we did consider the pitfalls as well, which Rachel will cover.
Yeah, so like many of you, you might be considering what could go wrong if you implement telehealth. And that's one of the things we did when we were considering jumping on early. One of the major concerns was, what if our local pharmacies, our high referral pharmacies, aren't going to jump on board straight away? And in turn, our patients who are loyal to those pharmacies choose not to jump on board either. We also have a pretty large elderly patient base. So are they going to jump on board? Are they going to be too freaked out by the technology? And then also our patients who have multiple scripts, are they going to be able to handle them through eScripts? And then one of the big ones was, eScript is a new technology. Is it going to have issues? How are those issues going to affect us? Are they going to put us behind? But for us, our worst case scenario was we revert back to paper scripts. They're not going to go away. They've been working for many years. We can go back to them. So that was our worst case. We went ahead.
I think it's important to remember that e-script complements paper script and it doesn't replace paper script. So on that note, we decided, let's do it.
Yeah. So first of all, we engaged our team. We started by ringing around some local pharmacies and seeing if they were going to jump on board straight away. It was also a really good way of gauging how they were feeling about e-scripts. Most of them were excited, positive, but also a little bit cautious, and that guided how we, sent out our first e-scripts to the pharmacies. Maybe we rang ahead and said, "Are you guys ready? We're going to send one to you." And then we got our IT team together, made sure that all of our medical software was up to date and that we were ready to start on day one.
I have to say we're pretty lucky. We had a really good team overall, and you'll hear from Ben next, which is our local pharmacy who worked tirelessly with us to make it happen. So after having all the team on board, then it was all the technicalities which Andrew had covered, and so we had a checklist. We already had ERX, so it's pretty easy. Some of you will have MediSecure. We already had the HPIO, HPII, and all we had to do was remember to validate the patient's individual health identifiers in best practice. And then that would then enable the eScript token. And we were already going to upgrade our medical software. Then the patient education bit, in hindsight, we did a little bit, but we could have probably done more with using videos. And we utilized Lucidchart, which is an amazing program for drawing up workflows very quickly. And finally, we use Automat systems for our appointment booking and online requests for scripts and referrals. So we set that up as well. So we were ready to rock and roll with eScript.
All right, so we put it into place, we jumped on board straight away, and these are the kind of things that we encountered and we learned. Straight away, there was an immediate reduction in workload for admin and GPs. It was a huge change overnight. It's extremely easy for a GP to send out an e-script within seconds. And our onboarding was super quick. Wei joined one of the online modules and did all the hard work, and then was able to teach our GPs in minutes to send out e-scripts. Our patients were completely impressed with the ease of the process, especially those who access a lot of telehealth. Being able to be sent your script within seconds of being on the phone with your doctor is so quick and easy. They didn't have to worry about whether they were going to get to the pharmacy and, oh, my script didn't arrive, or they can't find it amongst all the faxes. Our patients were empowered again. They could shop around for their script, whereas before they were having to decide on the spot, which pharmacy am I going to get this script from? It's just going to be stuck there. So we also found that it helped us collaborate with our local pharmacies better. We got to know people like Ben, who you'll hear from later. So it was just really nice to chat with them. But of course, there were always things that needed to be worked around. There was some technical issues. Luckily, we haven't had very many, just hiccups along the road. Initially, one of our high referral pharmacies had some trouble with their eScript software, and they were getting a bit frustrated. But we let them know, it's okay. We'll just send paper scripts again until you guys are ready. We checked in and asked, can we troubleshoot with you? And, we wanted to support them along the way. It was super important that we helped them through that teething process. And sometimes these things happen and you have to revert back to the old processes, and that's okay because they worked for so long. We can just go back. And our older patients, who we were a little bit concerned about, they surprised us. They've actually jumped on board and are super keen about e-scripts. We are, we can still send them an email script, or a lot of them opt for their script to be e-script to the pharmacy via email, which has cut down the time on the GP side, and they still get the same service that they liked before, and of course they can always have a paper script. We're really looking forward to seeing how Active Script List and My Script List change the way that our patients with polypharmacy can take up e-scripts. So yeah, we're super excited to see how that pans out.
So we like things short and sweet. So we'll wrap up now just with a couple of takeaways from eScript and really from what we've learned in COVID in general. I think there were a lot of positives overall. So firstly, be curious to alternative, more effective options that are out there. Secondly, be responsive to the needs of current times, especially in the pandemic. Listen to what is happening and do what's best for your patients. And then thirdly, employ a growth mindset. Give it a go. If you fail, it's not the end of the world. It's just a springboard for growth and for stretching our existing abilities. That was very important for us in COVID. And the next probably really important thing was the mantra that we had the whole time during the pandemic was progress over perfection. It was, nothing new is going to be ever perfect. Try it, adapt, make changes and make it better as you go. I also encourage everyone to be creative. Getting the GPs, the local pharmacies and the patients on board was quite interesting. We learned to package things up and we sold it really well and everyone got on board. So have fun doing that. And finally, what can I say? Embrace the future of medicine. Thank you.
Thank you so much. That was a very informative and great experience presentation. So thank you for that. I just want to say, please continue adding those questions. We have April and ourselves answering those questions. So that's really good. Thank you. I'd like to now introduce you to Ben Kang, our pharmacist at Carlton North Pharmacy. He will be presenting on a localized case study of e-prescribing in pharmacy.
Cool. Thanks, Sonia. Yep. Yeah, thanks, Dr. Lim and Rachel, and yeah, Andrew, who presented before as well, gave a good overview of what eScripts was all about and all that. So yeah, I am currently, I guess, in Carlton North Pharmacy, which is in Nicholson Village. Yeah, Dr. Lim and the Crane practice are actually one of the first practices which we got the eScripts from, which was really good because the collaboration between both of us and the communication, I guess, made the whole process a lot easier and easier to get to do it, I suppose. For me personally, there was a big initial change because always as pharmacists we want to check what the doctor writes on the paper, but there was no physical copy. You have to go back into the dispense system and check it that way. So yeah, it's a bit of a change initially, but yeah, the more we did it, the easier it became. So tonight I'm just going to go through a couple of case studies of patients at, I guess, we had at the pharmacy which experiencing using eScripts. So patient A, he was this person was quite a tech-savvy individual who had lots of apps on his phone. eScripts was actually good for him, especially during COVID, because now it was easier to organize delivery for this person because they didn't really want to come out of their house during the COVID season. So they could either just text us the eScript or either just send it to the email it to us, and we can get it ready and organize delivery for them. Previously, with paper scripts, this would have been a bigger hurdle because we had to get, I guess, the original paper script from the patient, and then get it processed at the pharmacy and then send it back to them, which I guess was a lot of back and forth between the patient and the pharmacy, which I guess increased costs and all that. But yeah, with eScripts, it was a lot easier to do deliveries during COVID. This person also, yeah, I guess previously it was quite easy to lose scripts because every paper scripts had to be eaten by a dog, or either they lose it or spill something on it. But for us, if they already got it at the pharmacy and if they accidentally deleted it by yeah, we could actually reprint the token for them, which made it a lot easier. And that's, yeah, we eliminate the them losing the scripts. Second patient I want to talk about is, I guess, this person who has a lot of medications and used to the paper script system. He used to be able to write on the back of his scripts what they were used for. We also would annotate stuff on their scripts to say, like, this one is for his blood pressure or for his cholesterol. But I guess for e-scripts, it was a big change for this person because they could no longer do that. Everything was on the phone now. So what we did, we actually just, I guess, reverted back to the paper. So we can actually print out the paper repeats for them, and then I guess sort of do it as per normal. But I think this person would benefit more from the active script list, because then they can just tell, I want my blood pressure one, or yeah. I guess also, like, in regards to the e-scripts, now with the only active ingredient listed on, like, active ingredient prescriptions, it may be a bit more challenging for patients because they were used to the brand names and all that. And being an e-script, you can't really annotate that this used to be called, like, Crestor, this used to be called Lipitor, which I guess is a challenge. So yeah, so that for that patient, we we just printed out the paper thing and then wrote down what it used to be and all that. In terms of workflow for the pharmacy, yes, as previously mentioned, it was easier to organize deliveries, less double handling and paperwork. It also helped reduce our time checking the scripts, because I guess, like, with the e-scripts with the barcode at the bottom and all that, it automatically pre-populated into our dispensing software. Yeah, and also there was no issue of the patient not bringing the doctor's copy, because a lot of patients, they would bring either just a yellow repeat prescription and not the doctor's copy, which would make it really hard for us to check. But now, yeah, with e-scripts, it's a lot easier. Also, we don't have to worry about forged assay scripts. Also, don't have to call the doctor up to verify the script and handwriting, because I guess, yeah, with the increased security and all that, it's, yeah, made it a lot easier and better. Oh, one thing that we had to invest in, we had to buy new scanners, because not all of our scanners could scan the QR codes. Yeah, so we have to spend a bit of money on that, upgrading our scanners. But yeah, on the positive side, there's less paperwork to file, less wastage of paper, and then, yeah, hence we don't need as much storage for the paper scripts. I guess another benefit that I found with e-scripts is that to go back and check a script, it's easier. Like, last time we had to sift through boxes and boxes of paper to try to find the original script, but now it's just so easy, just going back to your dispensing system, finding that original e-script, and be able to confirm what the doctor prescribed is what we actually dispensed and all that, and yeah, helps reduce errors. Yeah, that's all I have to say about the topic. Yeah, I'll hand it back to the organizers.
Thank you so much, Ben. That's a really well, I should say, a really great outcome for those patients using e-script. So thank you so much. I'd like to now introduce you to April Burnett from the ADHA. I'll hand it over to you, April. Thank you.
Excellent. Thanks, Sonia. So really good to hear the perspectives from both general practice and pharmacy tonight. I saw that quite a lot of people had some questions through the questions bar, which I have typed away with some answers just now. But my final sort of comment would be that I do encourage you all to access some more training that we have. The agency has some excellent online training modules relating to electronic prescriptions, and we're hosting more webinars. And of course, reach out to the PHN too, which are providing some support around connecting to electronic prescriptions. But yeah, really good discussion tonight. Excellent webinar. So I'll just pass back to you, Sonia, to close off the session.
Thank you so much, April. I'd like to thank you all presenters this evening for presenting such informative information on e-prescription. I'd like to thank all the attendees that attended tonight. Please, if you have any questions, further questions, please contact the relationship managers or your relationship manager at the Northwestern Melbourne PHN. Good evening, good night. Thank you.